antidepressants increase the risk of suicide in young people. In October of 2004, the FDA issued a black box warning regarding antidepressant suicide risk in young people ages 18 and younger. The black box warning is the most severe warning that the FDA issues. It's printed in big, scary, boldface at the top of the prescribing information, and it's surrounded by a black box, hence the name. The warning came after the FDA's British counterpart, the Medicines and Healthcare Products Regulatory Agency, MHRA, concluded that selective serotonin reuptake inhibitors, with the exception of fluoxetine, Prozac, should not be used to treat adolescents for major depressive disorder. As a result, the FDA conducted its own study and subsequently issued a black box warning for 9 antidepressants: Celexa, Luvox, Paxil, Zoloft, Prozac, despite the MHRA's finding, Effexor, which is not an SSRI but an SNRI, serotonin norepinephrine reuptake inhibitor, mirtazapine, Remeron, which is neither an SSRI nor an SNRI but increases both serotonin and norepinephrine by unique mechanisms, a medication called nefazodone, Surzone, which has subsequently been withdrawn from the market due to recorded cases of liver damage, and bupropion, Wellbutrin, which again is not an SSRI, not serotonergic at all. Not all of these medications were FDA approved for the treatment of depression in children at the time. Here's a table showing the current FDA indications for children with major depressive disorder, generalized anxiety disorder, OCD, and bipolar depression. Also, the antidepressant imipramine has long been approved by the FDA to treat diurnal enuresis, daytime involuntary urination, as well as nocturnal enuresis, bedwetting, in children older than 6 years of age. Of course, physicians they're always free to use medications off-label as long as in the best judgment of the physician, the risks and benefits of this medication warrant its use, and we can obtain informed consent from the patient or the legal guardian. And that means we can prescribe without the FDA's approval. But the perception among clinicians is that doing so increases medical legal risk, that is, the chances of being successfully sued for malpractice, even though off-label prescribing itself is certainly not malpractice. Still, the FDA frowning at you can cause a chilling effect. For example, I treat older teenagers, but I'm not board certified in pediatric psychiatry, and I myself would be loath to prescribe off-label, especially outside the scope of my practice, particularly in the face of a scary black box warning screaming in my face about the putative dangers of prescribing an antidepressant to a depressed minor. It can certainly cause a chilling effect, and that's exactly what happened. The FDA decided in October of 2004, but the labeling went into effect in January of 2005, and in May of 2006, following a slew of media reports, more case reports, but this time not in the scientific literature, in the media, the FDA expanded its warning to include all patients under the age of 25 and virtually all antidepressants, more than 30. The FDA's ruling was controversial from the outset because, number one, it was based on anecdotal reports, a retrospective meta-analysis of a bunch of studies that weren't even looking at suicidality, and because those meta-analyses were considered flawed, they were criticized as fraught with methodological issues, including, and probably most significantly, the fact that the FDA employed an independent reclassification of suicidality, which it did because there was a concern that there were inconsistent measures of suicidality across the trials that were being analyzed. Well, this is because the original studies they looked at weren't explicitly studying that connection between SSRIs and suicidality. How the FDA extrapolated to Remeron and Wellbutrin, we'll never know. But according to an article published online in 2019, in the Mood and Anxiety Disorders section of the journal Frontiers in Psychiatry, over the preceding decade, an increasing number of reports had questioned the actual validity of the FDA warning. The article called the FDA's action an exaggerated response, leading to an alarmist message. The FDA's action was also controversial, especially considering the fact that the decline in the prescription of antidepressant drugs that predictably followed was associated with an increase in the rate of suicidal events among people with severe depression. Did the labeling do more harm than good? According to the Frontiers in Psychiatry article, the overconcern raised by the FDA most likely proved to be effective in decreasing the prescription of effective medications. The rates of antidepressant prescriptions declined nearly 50% among all age groups, but especially in children and adolescents, while meanwhile benzodiazepine and antipsychotic drug prescriptions increased, especially in young females. Benzos, habit-forming sedatives, and antipsychotic agents, which have far more deleterious potential chronic side effects than antidepressants. For example, metabolic syndrome, i.e. diabetes, and tardive dyskinesia, which is a neurological condition characterized by involuntary movements, which in some cases is permanent. Also, the anticipated increase in psychotherapy to treat depression and to prevent suicide, which was expected by the FDA to offset the decrease in pharmacotherapy, didn't happen. Not only did antidepressant prescribing rates fall in the wake of this black box warning, but also the rate of diagnosing new cases, when there's no reason to believe that the actual incidence of major depression would have changed. That would have been some coincidence. No doubt this black box warning has placed a chilling effect on providers prescribing as well as diagnosing. So it appears that patients of all ages with major depression are less likely to be diagnosed with the disease and are therefore less likely to receive adequate treatments since the introduction of this warning. And yet, the FDA seems reluctant to retract it, even if it may rely on faulty research design or doesn't fit the real world, despite an increasing body of evidence that the warning is misguided. As far as real-life experience, my own admittedly anecdotal experience, I've never seen it. Again, I don't see children, and my experience with adolescents is limited. The vast majority of my patients are adults, but I think it's prudent with the initiation of therapy to always caution all patients of all ages regarding the possibility of paradoxical, intrusive, ego-dystonic suicidal ideations. Let me break that down. Paradoxical because suicidal ideations are both unexpected and the opposite of what we want, and particularly if the patient wasn't suicidal to begin with. Intrusive because these ideations are unbidden. Again, the patients weren't suicidal before, presumably, and if the medication is causing them to be suicidal because it's changing their brain chemistry, then these thoughts are simply going to occur to them, and they're not going to be due to some change in their situation or some worsening of environmental stressors or triggers. This is also, by the way, why it sought to affect only young people, because young people are more impulsive and they're more likely to act upon suicidal ideations rather than to reflect upon them and to have the maturity and the perspective to say, wait a minute, why am I feeling suicidal? I don't want to kill myself. I didn't want to kill myself before. I'm having these thoughts now. Better call my doctor. Better talk to my doctor. So that's sort of the putative reason why we would only see increased suicidality in younger patients. But it's speculative. Ego-dystonic refers to responses and behaviors that are against a person's beliefs and will. And so I always tell my patients, as long as it scares you, as long as you're alarmed, that's actually, ironically, a good thing. It's when it starts to sound good that suicide is dangerous. So I tell my patients, as long as it's something that is upsetting, that means you're not going to do it, and that means I have less to worry about. And actually saying that to them helps them to be less disturbed by the intrusive, morbid ideation that will improve, if it occurs at all. And so it's when a patient has ego-syntonic ideations about hurting themselves that we worry that it's something that they may actually do. And the ideations are passive when there's no plan. Active suicidal ideations require both a plan and an intention. But at the end of the day, I think it's more important to focus on risk factors that are known and universally accepted. Who's at increased risk of suicide? Patients with anxiety, patients with personality disorders, especially, in my opinion, clusters A and B, especially borderline personality disorder, but not so much antisocial personality. Patients who suffer from substance abuse, who are chemically dependent, and fat disease is active. The presence of aggression, and especially the presence of impulsivity, both of which correlate with cases of severe head trauma. We do see an actual increased incidence of suicide in those cases. And again, younger people tend to be more impulsive. Cases of severe neuropsychiatric disorder and cases with psychosis, cases in which hopelessness is a core symptom, cases that involve childhood history of physical or sexual abuse, and these are just to name a few. I think it makes more sense to focus on those risk factors. They're much more salient than the idea of which patients are actually receiving the treatment indicated for this condition, known to improve this condition, that are life-altering and in many cases life-preserving. The black box warning is not likely to be removed, but I think it should absolutely not discourage clinicians, especially psychiatrists. It should not preclude them from prescribing, even off-label, to young people that are bound to benefit from these medications. And for us just to be ever vigilant. And I think if we educate our patients and we obtain informed consent, and even very young patients, explaining to them that if they have these thoughts, they're just thoughts, it might be a side effect from the medication, and all they need to do is get in touch. And they don't need to be scared. And the same could be said to practitioners. We don't need to be scared.